Chapter 15, Part 2, we're going to continue with Radial ABG Procedure. We're going to pull the skin taunt with the finger of the other hand over the artery and pierce the pulsating artery at high degree. We're going to perform this at 30 to 45 degrees against the bloodstream. Little neurosuction is needed because the blood pulsates because it's an artery and flows quickly into the syringe. And this is what it looks like. We would hold the needle like a dart as shown here. The radial ABGs, when approximately 1 ml of blood is collected, withdraw the needle carefully to avoid introducing bubbles into the syringe, and we're going to apply gauze. Please be aware, since it's an artery, it will need a lot of direct pressure for 5 minutes or more. We're going to gently mix the blood in the syringe with the heparin and label the syringe, and the syringe gets hand-delivered to the lab. 15 minutes is best for optimal laboratory results. This is normally processed by a respiratory department. Before leaving the patient, leave a pressure bandage on the puncture site. If bleeding from the site persists, apply more manual pressure and ring for assistance. Never leave a patient who is bleeding, particularly after an arterial puncture. And then we're going to notify the primary nurse as well so that they can check the site frequently. I'm going to have you review this slide on your own. TDM, therapeutic drug monitoring, used to monitor the serum concentration of certain drugs. The drug is highly toxic. When underdosing or overdosing can have serious consequences, and if the use of multiple drugs may alter the drug action. If individual patients metabolize drugs at different rates, if the effectiveness of the drug is questionable, and if compliance with the medication regimen is a concern, we're going to draw serum concentrations on the patient regularly. This is a complex endeavor. It requires coordination between lab, nursing, and pharmacy. A trough level is the lowest concentration in the patient's serum, and the peak level is the highest concentration of the drug in the patient's serum. Please be aware we will go over this in detail, the time frame for these particular therapeutic drug monitoring tests. Transportation blood specimens for TDM should be maintained in an upright position during transportation. And please be aware the CLSI has devised toxicology and drug monitoring requirements for blood collection containers. Collection for trace elements. Testing involves the use of specially prepared trace-free evacuated blood collection tubes. Tubes and micro collection containers are available with low lead content to use in blood collection for lead levels. The lead tube tops are tan in color, and royal blue are used for our trace element testing. There's also specific specimen collection guidelines should be established as part of the clinical laboratory technical procedures. Genetic molecular tests. These are special informed consent must be signed by the patient for genetic molecular tests, and these are collected in a lavender top tube. For cryogenic testing, peripheral blood samples are usually requested to be collected in a green top tube containing sodium heparin. Please be aware that we also need to get patients' correct demographics, so their age, place of birth, parents, ethnicity, and race. We're going to transport these specimens. The genetic material, RNA, is only viable for approximately 6 to 24 hours, so the specimens must be sent to the laboratory immediately. IV line collection. This is a visual of what a PICC line looks like. A peripheral inserted central catheter can be inserted in the arm, up in the brachial armpit here, as you can see here. Normally has a single lumen or double lumen, and they can also be placed in the upper shoulder area by the clavicle. The PICC line, inserted into the arm or hand veins. A PICC is usually only used for blood collection when it's first inserted and can become easily infected around the area. It delivers long-term medication, IV antibiotics, chemotherapy, and blood product replacement. Phlebotomists don't collect from PICC lines, nurses do. So not usually advisable to collect blood specimen from the same arm. So we're going, because of concern of either the IV or PICC line being diluted with the fluids that the IV was placed with. If an arm with an IV is used, ask the nurse to shut off the IV for 1 to 2 minutes or the time required by a healthcare institution. After the venipuncture, ask the nurse to restart the IV immediately. Some facilities recommend a 5 to 10 ml discard of the first portion of blood to eliminate the chance of dilution. We're going to document this situation when laboratory requests detection of blood levels of substance that are being infused in the IV. So for example, if the patient was being infused with some type of sodium and we're looking at the sodium levels, we might want to document that situation just in case it could falsely elevate that particular lab value. Collecting blood through a CVC, I'm going to have you look over this on your own. Usually managers of the healthcare facility require nursing or laboratory personnel to take specialized training courses prior to allowing them to collect blood from the CVC line. However, in our setting, it's primarily the nursing staff who will collect these. I'm going to have you review these slides on your own as I will go over them in detail in class. This is just the supplies and equipment the staff would need to collect from a CVC line. Please be aware we need to check the patient's chart for physician's order to draw blood from the CVC line, because if we do not have a doctor's order, we cannot take from that line. This shows the nurse swabbing the cap. They swab the cap to get rid of any possible contaminants that might be on the outside of the cap. They're going to flush it with saline, and then they will clamp the catheter, remove the syringe, and insert a new needleless 10 ml empty syringe and this would be used for their discard. They're going to swab the cap again with a new swab, and they're going to now insert the 10 ml syringe into the cap and aspirate the required amount of blood. Please be aware that they swab the cap several times throughout this procedure. They complete the procedure by irrigation of the catheter with another 10 ml saline syringe. And at the end, they change the cap. The cap should be changed after each blood collection. And the nurse then determines if the IV is transfusing properly. Please be aware that make sure the patient is safe and comfortable position with the bed down, side rails up, and bedside table, and call light nearby once the procedure is done. Collecting blood through the CVC line, again, please immediately label and transport the blood specimens. Sometimes the nurses will hand us off the tubes and we will bring them to the lab. Cannulas and Fistulas. Cannula is a tubular instrument that is used in patients with kidney disease to gain access to venous blood for dialysis or blood collection. Fistula is an artificial shunt in which the vein and artery have been fused through surgery. Avoid collecting blood from the arm with a fistula. I will be giving visuals of this in class. They are unmistakable. You would notice something isn't quite right when you go to palpate that area. Donor room collection. This is if you decide to go into donor phlebotomy. So there is a donor interview that takes place. We need to know the date and time of donation, for patient's first, last name, and middle initial, address, telephone number, gender, age, and date of birth, written consent form signed by the donor, and record of reasons for deferrals. They also need their social security number, name of the patient or group to be credited, race, unique characteristic about the donor's blood. And prior to collecting from a donor, we will do a brief physical exam. We get the patient's weight to determine how much blood we can take from them at any given time, temperature to make sure that they are not ill, collect their pulse and blood pressure, because if there's any issues with these, they would be then ineligible to donate. Noticing skin lesions, general appearance. They check their hemoglobin and hematocrit values to determine if the patient's anemic, and extensive medical history. Collection of donor's blood. Blood should be collected by using an aseptic technique, a sterile closed system, and a single venipuncture. The healthcare worker should be well versed in donor reactions, equipment, safety precautions, first aid technique, and location of first aid equipment. Again, I'm going to go over this in detail in class. Please remember with donor collection, this is where we would use that 19 or 18 gauge needle. Autologous transfusion. The patient donates his or her own blood before anticipated surgery. This is the safest blood a recipient can receive is his or her own, because then it eliminates the formation of antibodies in the transfused patient. Therapeutic phlebotomy, intentional removal of blood for therapeutic reasons. For treatment of myeloproliferative diseases such as polycythemia and hereditary hemochromatosis, or other conditions in which there's excessive production of the blood cells. This is the example of them verifying the patient, and this would be the small bag that they get from the patient. It's very, very little. We just need to get enough off the patient because they might be overproducing red blood cells. So the goal is to take some off so that that way their body can start producing more. That concludes chapter 15. I will be covering a lot of this information in detail in class, especially the blood culture procedures and the special lines that we might view or access.